We have been organizing this rural healthcare session since the last 10 years, I think. Here with me is Dr. Rajbhai Dongal. He is a surgeon in our institute. So I would like to start the introduction from Dennis. Please, will you please introduce?
Yes, good day, everyone. This is Dr. Dennis Batangan from the Philippines. I work with the Ateneo de Manila University as a faculty and as a research scientist in our School of Government, the School of Social Sciences, and the Institute of Philippine Culture. Thank you for the invitation and this opportunity to share our experience in the Philippines. Thank you, and good day again, everyone.
Yeah, thank you. So in APAN venue, is there someone in APAN venue?
Hello.
No.
This is Mariama from APAN venue.
Yes.
Thank you for inviting us to the Rural Healthcare session. It's a very good opportunity to join this session. We hope you to have a fruitful discussion. Thank you so much.
Thank you. There is someone from Kyushu University. Kyushu University, will you please introduce?
Maybe only engineering.
Hello. Hello.
Yes. Yes.
Hello, this is Kyushu University. I'm Saori Matsuda from Temedec. Let's enjoy the session. Thank you.
Thank you. Next from Nepal Research and Education Network. Will you please introduce?
Hello, everyone. My name is Nirajan Prajali. I'm working in NREN. Thank you.
Thank you. Next, Dr. Uman John, will you please introduce? Dr. Uman John.
Hi, I'm Dr. Uman John. I'm dialing in from New Delhi. I work at the Bill and Melinda Gates Foundation in New Delhi.
Thank you. Thank you, Dr. Uman. Nice to see you.
Thank you.
Next is Michael from Taiwan. Will you please introduce? Michael Su. Michael, are you there? Okay, next, Dr. Sudeep Shakya, will you please introduce?
Hey. Namaste, everyone. I'm Dr. Sudeep Sakya. I'm a surgeon in Kathmandu Model Hospital. I'm not with my team right now, but I'm joining from my other place. So looking forward for this session. Thank you.
Thank you. Pawan Sakya, will you please introduce yourself?
Hello, my name is Pawan Sakya. I'm the Vice President of Telemedicine Society of Nepal. Thank you.
Thank you. Michael Su, are you online? Michael? Dr. Shreya? Dr. Shreya, will you introduce yourself?
Namaste everyone. I'm Dr. Shriya Karmacharya from Kathmandu Medical Hospital. Sorry, Model Hospital.
Okay, Chang. Mr. Chang, will you please introduce?
Yes, yes. Hi, this is Tizhuang Jiang from National Taiwan University, and I'm so glad to can join this session again. And I hope my friend Michael joined too. We just got this URL at the last moment. Okay,
Yes.
wish we have all have a wonderful time.
Yes, thank you. Thank you. Michael, we can see you now. Will you please introduce yourself? I think you are mute.
No, I think he's still not connected with the audio.
Yes.
Yeah, his video is on, but his audio needs to.
Yes. So maybe we should start with the presentation. First, our presenter is Dennis from Philippines. He will be giving us some insight on the phases of technology adoption and health governance for rural healthcare in Pangasinan province. Dr. Dennis, please.
Yes, I'm just sharing my slide. Hope it gets through and you're able to see it.
Okay.
Good afternoon, everyone. Again, this is our good day, to everyone. This is Dr. Dennis Batangan from the Ateneo de Manila University, and I'm glad to see Professor Chang. He's an old colleague from APAN and from way back. This is actually a presentation to describe our experience in response to the theme of this conference, on the experience of one province in the Philippines, it's Pangasinan province, which I will describe in more detail later in terms of their technology adoption and health governance in rural healthcare. The objectives of the presentation include to provide an overview of the universal healthcare implementation in the Philippines, to describe the health governance and technology requirements for local health system development in this particular province, and to present updates on a project that we're doing in this particular province. The map on the right shows you actually the map of the Philippines. It's in the ASEAN region with 7,000 islands, 7,000 plus islands, and the arrow actually points to the location of the province in the northern Philippines, where in this particular presentation is being made. As you know, the ASEAN member state countries include these following countries, including the Philippines. And lately, the new member is Timor-Leste. So that makes the ASEAN member states to be 11. What you see on the lower part of the slides are actually some basic demographic indicators of the Philippines, including the current the population as of 2020, which is around 110 million. The universal healthcare in the Philippines was implemented or was approved in 2019, and this is how it is actually articulated in terms of a diagrammatic representation, wherein the national development goals are actually linked, to the goals of universal healthcare implementation in the country. This is actually a recent document, the Philippine Development Plan, which includes actually a health system strengthening indicator on interoperable systems, that makes the e-health or the adoption of e-health technologies as part of the national development goals. One of the major reforms in our universal healthcare implementation is the further local autonomy of local government units, provinces and cities into what we call province-wide and citywide health systems, wherein these health system implementations, including the information management system, is actually implemented. What you see here is actually one of the key result areas for universal healthcare implementation in the Philippines, which looks at the different sub-KRAs with regards to the information management system. And actually, the information management system and other KRAs being tracked through what we call the local health system maturity level. But you see at the bottom of the slide actually is a tracking report on the implementation of maturity level indicators with regards to the provinces that are actually implementing universal health care. The direction is actually towards more local health information exchange. No? What you see on the left actually was the diagrammatic representation of a Philippine health information exchange prior to the universal healthcare implementation. With the universal healthcare implementation, we're moving more and more to province-wide and city-wide local health information system implementation. Moving now to the Pangasinan province, no, this is actually again another map, no, where it is located actually in the northern part of the Philippines. It has a population of around 3,665,000 households. There are 3 we call component municipalities and 44 municipalities. It has more than 1,000 villages, 15 government hospitals, and around 40 private hospitals, and 70 rural health units, which are actually distributed in the different municipalities and cities, and more than 600 barangay or village health stations. This is a map of the province which shows actually the distribution of the interlocal health zones, no, in this particular province, and the number of hospitals, no, around the province. So the question is actually, how do you manage the information flow with regards to a big province, no, such as Pangasinan province? This is actually this borrowed slide, no, from the province provincial health office, which shows the flow of information. This is not an electronic reporting. This is a manual reporting of data coming from the private and the public side in terms of how the provincial health office, no, PHO at the middle, actually receives the reports and sort of validates the report before it's submitted to the national office, which is the regional office of the Department of Health. So the yellow actually shows a data quality check process initiated by the province before on the reports that are being sent to them before they are reported to the higher offices. No, again, this is still a paper-based process as of now. So they are moving actually to more electronic reporting as part of universal healthcare implementation. Part of the monitoring process for the province is what we call the LGU, or the local government unit report card. No, you will see here an example of the report card, which includes elements of the health information system. So there are color codes, no, in terms of the reports, no, whether you are green, yellow, or red. No, green meaning that you have achieved the targets, internal and internal standards. No, yellow means that you achieve the internal standard but not the external standards, and red means that you have not achieved the internal and external standard. What you see on the right actually is a photo of the provincial health office in the capital town of Lingayen in Pangasinan. And what you see on the right is a photo of a rural health unit. And on the lower left of your screen actually are the health staff, no, in one of their summits, wherein they actually receive awards, no, for performances over the year in their local government unit. And this screen, the COVID-related photo on the right lower end is actually part of the COVID response of the province during the COVID period. The project that we are working with in this particular province is actually to work with them through a techno-governance approach in developing what we call a smarter integrated local health information system, or SMILIS. So the work actually has a technical part, which includes the architecture, the technology, but it starts actually, the basic part is the governance part of the project in this particular province. And it boils down actually to a plan. No, this is called the ICT and e-health development plan, which we actually help them develop and of course fill up and of course submit to their to the higher authorities and to the local authorities. It actually looks into the ICT and health development plan for in terms of their vision, mission, goal, mandate, functions, major final outputs, their programs and projects, and of course budget and cost estimates. So we sort of develop with them a provincial strategic plan as part of the project inputs so that they can actually articulate their vision, mission, and goals in relation to the universal healthcare implementation and the requirements of the universal healthcare implementation in terms of developing an integrated health management information system. And of course, together with that is the local health information exchange that will link actually the primary care network to their secondary and tertiary providers. Also, develop and work out with them a multi-year plan, no? Because the setting up of this strategic plan and its requirements will take several years, no? And it's actually a continuing work even more than 7 years. So it starts with actually the foundational systems of which we are providing them through this project. And the direction is actually to start with the public facilities first, with the pilot public facilities, moving to the next phase or the next level or the next cohort of public health facilities before moving to the private health facilities in that particular area. And of course, moving to the other health related programs and facilities within the area. That is actually beyond the health sector. The mandate actually will have to link their vision and mission and goals to national laws, no? Which in this case is the Universal Healthcare Law, which is mentioned here as Republic Act 11223, and of course the Philippine Development Plan, which I showed a bit earlier. As far as the functions are concerned, we sort of again worked that out with them, the articulation of the functions in terms of facilities of data storage, systems automation, interoperable platform, the interconnectivity within the province, contingency plans, linkages with ICT and e-health related institutions, and of course the capacity building part, which is the function 7 in this particular enumeration. These are actually translated in what is required in the Philippine bureaucracy as major final outputs. These major final outputs are the ones actually being monitored when they submit the plan to higher authorities. So we divided it into 4, MFO1 or major final, looking into systems automation, systems upgrades, MFO2, structured networks interconnectivity, and MFO3 on e-learning and management system, and MFO4 on institutional partnership. So you'll notice now that the development of this plan actually is more of a systems approach, no, not focusing on the technology part, not only focusing on the capacity building part, but also the institutional partnerships needed to be able to maintain the system that they develop. And then we go into the listing or identification of program project activities. Again, this is a requirement of the Philippine bureaucracy in terms of identifying for your plan the existing programs, projects, and activities so that you could actually map them out, no, over several years, no, for in this case 3 years or probably longer, so that you identify the programs, projects, and activities, including the amount of no, that or cost associated with this project, and who is funding it, and who are the participating institutions, so that you could actually see where you are in this particular plan and how you will proceed or probably generate more funding in the coming years. Just to show you the open architecture design that we are developing with Pangasinan and other LGU local government unit partners in the Philippines, which actually is a local health information exchange for our universal healthcare implementation. The most critical part, of course, would be the authoritative registries at the bottom, citizens, facility, and health worker registry, and of course the use of the technical solutions like HL7 Fire which has been adopted by the government as the main technical solution for interoperability. This is a screenshot actually of the portal or the site, for the province, wherein the local health information exchange is being set up. No, it's still being set up because of the customization and of course the setting up of the exchange, with the other component municipalities and cities. What you see on the slide on the right actually is the customization process, wherein the facility, the name of the municipalities will have to be customized in the system for the province using the Philippine standard geographic codes. So the system starts adapting now the national standards in terms of codes for provinces, codes for municipalities, codes for facilities, codes for diseases, so that the system, once it starts implementing its use cases, actually can talk to each other using the standard codes that are in a sense required by the system, by the government. That's it for now. I just want to highlight that in this particular technology adoption and health governance process, we are now in the phase of actually working on a development plan, which looks at actually the governance part, the technology part, and the capacity building part for adoption of a electronic health information system to support or for the implementation of universal healthcare in the province of Pangasinan in the Philippines. Thank you and a good day, everyone.
Thank you, Dr. Dennis, for a nice presentation. So, is there any question or comment on his presentation? So if there is no question or comment, we'll move to the next presenter, Michael Su. He will be presenting on smart healthcare in rural area. So Michael Su.
Thank you, Dr. Udaya. Okay, and I'm Michael Su. Good afternoon.
Will you also please introduce a little bit first?
Oh, sure. Let me share my slide first, okay, which will also introduce myself, okay? Please give me a moment, okay? Okay, I suppose everybody can see it now. Okay, I'm the CEO of Cure Doctor, which is a telemedicine platform, okay, company, and also the founder of Wise Love Public Service Alliance, which is an NPO. The NPO's mission is to improve healthcare service for vulnerable people and for people in the rural area. Okay. Today, I'm very honored, okay, to have the opportunity to share the Taiwan experience about how we use digital smart technology in rural area to improve the quality of healthcare. And this model is characterized by organizing multiple stakeholder partners, using a digital platform to link all the relevant institutions, people, device, data together to do seamless collaboration. The highlight is to leverage enterprise ESG/CSR donation and work with the local government health bureau to speed up the healthcare in rural area. As you know that, okay, funding always a problem for the government. So we leverage the enterprise donation to make it happen sooner and faster, okay. The problems we want to deal with, is the 4 point. The first is the high transportation cost and time to see a doctor. And the second is the delayed medical care create greater medical and social cost. The number 3 is various inspection data are scattered in individual institutions. Number 4 is local government links a people-centered digital platform to provide the sustainable healthcare service. This is our solution, okay? Our solution is to build a sustainable, comprehensive healthcare service that combines relevant stakeholders. Number 1 is to partner with local government, okay, to take lead of the action. Number 2 is to build a health care cloud as the core infrastructure, as you can see this diagram in the center. And to provide the 4 services, which including interactive video education, preventive healthcare, AI-aided telemedicine, and itinerant physical examination. Okay, this is to enable collaboration across the multiple stakeholders, and we want to establish a people-centered healthcare service. And this diagram shows you the model we use to do the O2O preventive care. Okay, from the left to right, you can see that, okay, we leverage local government power to connect the daycare center, public clinic, and hospital together. Then in the daycare center, the caregivers measures vital signs for the elder every day. And the platform will automatically notify the designated nurse and the family member for the abnormal case. Then nurse does telecare to elder according to the job dispatching card in her account. Nurse can also invite elder's family member to join the consultancy. I think it is very helpful for the healthcare. Then nurse can further assist the elder to make an appointment with clinic doctor, either by online or by offline. Nurse can also assist transferring the elder to local hospital if it is required. Okay, and the government health bureau can monitor all the service data via web in real time, and the donating enterprises can get the service report in their account. Okay, they can use it for their ESG CSR report. Okay, so this is the model we employ, okay, for the preventive care. And this page in the upper side, okay, we show you the smart IoT devices that we deployed in daycare center. In the lower side is the devices that we use in itinerant, okay, examination. The reason why we choose to work with the daycare center is there are a good infrastructure in the daycare center. The elder people in the care center, they can get free lunch, entertainment and culture course, and they get accompanying and healthcare. Okay, and the resources we can leverage is there are 2 caregivers in each side, okay, to serve about 30 to 40 elders people, and they have a high quality venue, and they have TV, PC, and broadband, and we connected the online care team and the online offline clinics and hospitals to provide O2O service for them. And these pictures, okay, show in the care center, okay, the caregiver doing measurement for elders and the doctor doing telemedicine for the elder. And this page shows the web-based service report. Okay, you can see that, okay, for each stakeholder, they can get their report according to the authorization. For the donating enterprise, they can get all the service report for those daycare centers. Okay, they they donate. In this page, you can see there are 7 stakeholders in the systems. The government is in the centers. We work with a government health bureau to take a lead of the action. So we can leverage their power to ask a clinic, a hospital, and daycare center to join the plan. Then we use QDoctor digital platform to connect everybody and co-working together to achieve our ultimate goal, to improve healthcare in rural area. The motivation for government, to help to work with to do the plan is that we assist the government achieving 4 of the 17 sustainable development goals without any charge. We leverage enterprise CSR donation to pay for it, which including IoT devices, AI, video health education, and the telehealth care platform. In this eco-partner system, we make every stakeholder happy. Everybody can accomplish its own goals. Our company also successfully turned our public service into a sustainable business. And this is the last page. This diagram shows how it works among all the stakeholders. You can see the government in the center, and the wildlife NPO accepted the donation, and then further providing the devices and video health education to the health bureau, and our platform donate our platform for the health bureau to establish healthcare cloud, and the health bureau can assign the clinics, local clinics, and hospital to take care those daycare center, and then the government dispatch the IoT device to the daycare center and connect them to the local public clinic and the hospital, so they can do telecare and telemedicine service. And the government also work with university to provide them the healthcare data, and eventually we looking forward to get a research report to prove the effectiveness and the influence and the change of healthcare for the rural area. So this is my report, and thank you for your listening. And I look forward, to have further discussion with you and to discuss the opportunity of cooperation, especially about improving healthcare service for vulnerable people in rural area. Thank you.
Thank you, Michael. So I would like to thank Professor Chang for introducing such a nice person to us. So do you think it is replicable to other countries like Nepal also?
Sorry, I beg your pardon, please.
Do you think this is replicable? Your model is replicable in our country also?
Yes, of course. You know, I'm a member of a Rotary Club, and Taiwan. In past 4 years, there are 2 teams from Taiwan to do the public medical service. In Nepal, and I think the way they go there, spend a lot of money in the transportation and left a lot of carbonate footprint. It is a better way to provide a system, connect the Taiwan's resources and doctors, resources, and also IoT devices and the platform to help your country, to improve the healthcare for rural area.
Yes, yes, thank you. Because in this platform, we have rural healthcare workers who are working with us also. So, Mr. Balaram Neopane, do you have any comments or any queries? Balaram, sir? केही छ भन्नुपर्ने?
नै डाक्टर ठिकै छ। नमस्ते है सबैजनालाई। नमस्ते एभ्रिवान।
भिडियो अन गर्नु न।
यता अलि एन्टिलाइट
ठिक छ।
ठिकै छ डाक्टर, खासै त्यस्तो त केही छैन। म भर्खर जोइन गरेको हो, यहाँ अलि पेसेन्ट फ्लो धेरै थियो त्यही भएर। ठिकै छ, मैले त्यति धेरै अगाडिबाट सुन्न पाइनँ, त्यसको लागि सरी।
No, it's okay. So I just want to check this network connectivity. Do you think it is okay? Because he's from one of the rural area of Nepal. So because now the connectivity is getting better, so I think this is also smart health is also possible in some other parts of the country. Thank you, Balramji. So is there any other questions or comments? If no, then we'll go to next presentation. Next presenter is Dr. Oman John from India. He will be presenting on innovations for strengthening primary health care. Dr. Oman, please.
Thank you, Dr. Udia. Thank you for APAN organizers for having me at this. I was really hoping to be there in person, but unfortunately I could not. Please allow me to share my screen. Are you able to see my slides?
Not yet.
Oh, okay, just give me a minute.
Nirajanji, have you? Yeah, now we can see.
You able to see my slides?
Yes, Dr. Oman.
Okay, so thank you for this opportunity. And as a quick introduction, I am trained in medicine and I work as a country lead for health system design, data and insights at the India Country Office of Bill and Melinda Gates Foundation. Today, I'm going to be talking about how we can improve health outcomes for approximately 400 million Indians towards universal health coverage. This is a project that we're currently supporting the government of India with. So one of the things that we all know is that when people who are from the working class fall ill, there is opportunity cost, and also they spend a lot of money out of pocket, and that causes them to be pushed into poverty. And expanding this health safety net is part of what we call our road to universal health coverage in the Indian context. So we want to strengthen the accessibility, availability, and quality of healthcare for beneficiaries of the employee insurance scheme through reducing the friction in patient's journey and enabling observability. So the primary goals are reducing the friction in patient journey, strengthening the quality of care, and increasing the utilization of government-sponsored health insurance schemes. In terms of going about this project, we believe that every stakeholder in the ecosystem needs to contribute. So we have consulted beneficiaries, employees, employers, health facilities, shared services, as well as the leadership team right across the ecosystem. So this healthcare transformation for this 400 million Indians is based on 7 pillars of making health delivery observable. It is clinically excellent. It is centered on the beneficiaries. It is driven by clinical protocols, that is evidence-based, and it is future ready, that is empowering governance, as well as it is available to the citizen 24/7. So in terms of observability, so we want to be able to see who needs to do what in terms of health services delivery and compare it with who is doing what, so that we are able to look at the delta, and the variability in care can be minimized through this approach. So let's assume that Meda is a village-based factory worker who is suddenly feeling unwell. And in our system, we envisage that she can actually, instead of going to a clinic or a dispensary that she was earlier needed to go to when she is not well, she can actually pick up a phone call or go into an app and seek care. And at the other end of the application is actually a person who is trained and equipped to ask clinically relevant questions that will help in triage and quickly identify if it is something that needs immediate attention or that can be given an appointment at a dispensary or a hospital. So in doing so, we are able to also make sure that there is complete trackability and traceability of what is happening to this individual who is seeking care. And as I mentioned, many of these workers, particularly gig workers, when they are absent from work, they lose money. And if they are part of an employee ecosystem, then automatically making sure that leave notification is directly sent to the person who is employing would be useful. So let's assume that Meda was given an appointment and she visits the doctor. There is already a pre-populated patient health record based on the interactive questionnaire that is generated through the call center. And if there is any complications or any medication related issues, it can be. And if there are any complications, he or she can also contact the helpline operator post the diagnostic visit as well. So what are we trying to say? We are saying that the first point of, there are several studies in India that have said that it is usually at the first point of contact that the maximum harm is done. So usually they are given wrong advice or they waste a lot of time in actually coming to the right kind of healthcare facility, coming to the right kind of specialist if specialized care is needed. And a lot of money is also wasted in the process. So can we create a platform? The question here is, can we create a platform that will serve as the primary care coordination, the first point of contact, that is actually manned by a state level command center, which is interlinked to our 104 and 108 ambulance services. So if there is an emergency, the call center will be able to immediately redirect the person to wait for an ambulance, and based on availability of the ambulance in the locality, an ambulance actually reaches the person and the person is moved to a healthcare facility as needed. So the other pivotal part with that we envisage is that underlying an electronic health record of patients can be automatically generated through this call-based approach, and the resistance from the health delivery system to adopt electronic health record can be actually overcome. And we are trying natural language processing across different languages and dialects, and using SNOMED CT as the vehicle to transcribe that into machine processable information. We are in the process of generating this electronic health records. And based on electronic health records, one can also look at whether the correct clinical protocol was adhered to, if there is any specific deviation from the protocol, and real patient electronic health record and real patient transaction can be used for actually giving ongoing professional development or CMA. So what we have done is 10% of all electronic health records generated on a daily basis is sampled. And from that, an expert review is conducted, both using machine as well as using a specialist review. And anything there is a deviation or where they have done extremely well, that is reviewed. And then during the monthly clinical review meeting, these are taken up. And it has been extremely useful to know that having an electronic health record as the fundamental basis for both observability and for looking at practice patterns has been extremely useful. So going on to, it's a very simple process of registration. I will skip this in the interest of time. So if you were to look at the enterprise architecture, what we are saying is that there is a master database of all registry. And as you may be aware, or I want to make you aware, that in India, under the Prime Minister's Ayushman Bharat Digital Mission, we have been able to create registries for doctors, for drug dispensing units, pharmacies, laboratories, all healthcare facilities. And because of these master registries being available, we are able to allocate role-based machine-readable workflows, and this can be actually integrated with the workflows. And on the front end, what this gives to is real-time, activity-based, location-based data updation, and it's able to track role-based dashboards to understand performance and automated linkages to the annual performance cycles. And then in future, we would like to use AI-based personal adaptive questionnaire for actually being able to capture directly by the patient. Today, it is intermediated through a mid-level provider who does the phone call based, but in future, we are hoping that through, again, leveraging NLP and the language-based approaches, we will be able to actually capture the case directly into the personal health record. So another major aspect of what transformation that we want to bring about is quality assurance. So let's assume that Aarti is a patient who has gone into a healthcare facility because she was pregnant. And then after she has actually visited, there is a mechanism by which an interactive voice-based call goes to her, and then she is asked a series of questions regarding, based on actual her visit, what happened, what drug she got, what was the procedure that was prescribed to her, and how her experience was. And we are also hoping to be able to embed the quality of life questionnaire into that, so that we will also be not only looking at it from a health point of view, but a patient's perspective on the quality of life. So this can also help in understanding what is the medicine availability, what is the necessary interventions that need to for improving the treatment, and if there is a long waiting time, then rationalizing the waiting time based on this feedback is something that can be achieved. So finally, what we do not measure, we do not know, and what we cannot see, we really don't know. So what we are also working on is granular dashboards based on, I'll just take you through the simple dashboard as a metric that we are using: the number of patients who are being treated by dispensary and by district, and also at each state level, adherence to the treatment protocol, treatment time taken per diagnosis, and what is the patient's rating, and therefore thereby being able to arrive at an overall performance. And we are saying that this dashboard should be available to all people who are key stakeholders, including people who are allocating budgets, people who are reviewing, people who are responsible for quality assurance, as well as for the people who are doing the overall oversight in terms of finance, commission, and others. So again, like I said, we are saying that each of the district will be provided opportunity to describe the weightage that they want to adhere to, assign to each of these parameters. They can add additional parameters if they want, and then even within the district at the primary care level, by primary care unit, they are able to track this. And similar scorecards can be prepared for all facilities, department, and at all geography levels. In the interest of time, I will just pause here. So this is just an overview of what we've been working on with the employee state insurance scheme. I've not gone into too much of the technical details, but then giving you a conceptual overview of what we are trying to do in supporting this particular segment. A large proportion of these people, informal workers, come from rural areas, and that is where the rural healthcare component, that is technology levered, is going to be helpful. Thank you for this opportunity, and I am available to take any questions.
Thank you, Dr. Oman, for such a nice presentation. And we also know a lot about your plan and your program in India, and we hear very much good news about your Iceman and this healthcare. So I would like to ask you a question. This service seeker, they of course will be using this, and what is the feedback of the service provider? So their readiness and how willing are they to be connected with this and provide the services?
Thank you, Dr. Udhya. There is need to, because the health service providers are not used to this level of transparency. and accountability, there is a bit of hesitation. Nevertheless, both in terms of we need to incentivize them. Incentive incentive, what I mean is not just saying that you will get an incremental X rupees per patient, but actually demonstrating that there is X amount of unserviced captive population in each of the areas, and they are sitting with X number of conditions who can be easily covered under the insurance. So when you have data that is able to say at the population level that there are, let's say in a population of about 1 lakh citizens, if there is 10% prevalence of diabetes, we know that at least 50% of them are necessarily needing some medical intervention. So when there is no outreach mechanism, no mechanism by way in which they can be connected to the healthcare providers, that is a market that is lost. So one way that we are engaging healthcare providers is giving them opportunities for wider coverage in terms of actually increasing their footfalls, and also a reverse accountability. Accountability not only comes from the healthcare provider, but in terms of the government and the insurance scheme being accountable. So one of the things that we are working towards is performance-based payout times. So if there is a hospital that is going to be adhering significantly to the protocols and they are doing extremely well, not only should they get about 10% incremental of the claim, but also the turnaround time for them should be in real time. So we are working on financial reforms around that. And perhaps this is some ways of engaging the private sector, particularly those who are hesitant to participate in something like this. Thank you, Dr. Odhya.
Thank you. Thank you. Is there any question coming to Dr. Oman?
Sir, I just had one quick question. This is Abhimanyu.
Go ahead, Abhimanyu.
Thank you for that wonderful presentation. The gig workers are, it's a floating population, right? So what's the ID management scheme? Is it Aadhaar or is it just?
So at the moment, according to the Supreme Court, Aadhaar should not be made mandatory. So
okay.
What is under the Ayushman Bharat program, there is something called the ABA ID. It is basically an address. It's an ABA address.
Okay.
Sorry, I lost for a minute.
You were at the ABA ID.
So
maybe we can come to that later.
Yeah.
No issue. No issue.
Okay, Dr. Oman, are you still there? Okay, we'll go to the next presentation. Is from Sanjay Paudel. Dr. Oman, sorry,
Yeah, I was having some technical difficulty. I'm sorry. So can I just answer that quickly?
Yes.
So like I mentioned, ABA ID is a virtual ID. It can be linked to Aadhaar, or it can be any other identity proof that is given, and using that as a linkage. And then we have already introduced portability of the insurance. So irrespective of where they are, they can access. Earlier, it was restricted to a particular geography or a particular state. Today, anywhere across India, the insurance is portable.
And it's not, citizenship is not necessary, right? I mean, it could be somebody.
They need to have some form of ID. As long as they are eligible according to the ID to be part of the beneficiary scheme, they should be able to get that.
Sure. And you just one, sorry, a quick question.
Yeah, sure.
All this gets reported to the national reporting systems within India.
Yeah, within the ABDM, yes.
Sure. Thank you.
Thank you.
Thank you. Thank you. Thank you, Dr. Oman. So we will move to the next presentation. Next presentation is from Mr. Sanjay Paudel. He's IT engineer with a special interest in digital health, and he has been developing so many softwares and health products related to IT and helping us a lot. Now he's presenting on hospital to home, a digital health implementation journey. Sanjay, please.
Thank you, Dr. Uday. Am I audible?
Yes.
Yeah, thank you. Thank you, Telemedicine Society, for providing me this opportunity, and APAN. As Dr. Uday mentioned, I've been to the health IT sector since last 10 years. The organization that I'm associated is Sunne Computing, who is dedicated with providing the solutions and implementation support to Nepal government as well as the different non-profit organization. You can see in my slide, there are 4 different entities who are, we are closely working together just to ensure the proper implementation and design of the digital health along with the telemedicine is developed. So without further delay, I would like to start with why we need to have the evidence-based and why this platform is created. The vision is to develop the evidence-based integrated and which can carry the healthcare need of Nepal healthcare system, which should be responsive and accountable to on the basis of the requirement on the hospital as well as for the patients. So what are the key differentiators? We have added the requirement of the Nepal's government healthcare design. We believe the healthcare service delivery is not only with curative or with the hospital, but also needs to be scaled up to household level. That's why we firmly believe, we firmly practice home to hospital and vice versa, for which we have designed the technology based on those requirements. All of those data, whatever we collect from the hospital-based data or from the community health program, we use that for the learning and learning, monitoring, and evaluation, and also for the administrators and for the policy. Since we strongly advocate the open source model so that the innovation and the technology can be transferred to other countries or any other institutions, so we develop all those softwares, all the digital health tools, and make it open for as the global goods. So here is the simplified version of integrated municipal care model, where patient records will be there and community healthcare is there, for which we are using the community health toolkit, which itself is the global good and is used for the longitudinal care and follow-up for to the household level as well, where community health nurses and community health workers, they use the community health toolkit, whereas for the hospital, we use OpenMRS-based implementation, which is itself supported by Indian University, and in Nepal, we have localized OpenMRS as the Nepal EHR, which is also connected with HealthPost, as I mentioned, HealthPost, hospital, and community healthcare. So these are the 3 points of services which needs to be connected, and we have successfully connected these 3 tiers of the healthcare structure. On the basis of the data that has been captured is used by the Department of Health Services as the HMIS reporting, where DHIS2 is integrated, and every month all those data are synced back, or aggregated data is updated to the DHIS2. On the basis of the same data, even municipality and local governance can use that as the evidence or as the decision support for the governance, local governance, which we have named as the population health dashboard. So this is the ecosystem of the technology along with the community health program. Telemedicine at the community side, use the data that is leveraged from the facility-based implementation, where lab, clinical, radiology, and supply chain are interconnected and are linked with every services within the hospital. In the given slide, I would like to highlight the telemedicine module as well, where we have envisioned to use as the hub and spoke model, which means the hub and the spoke, let's say the hospital and the health post or PHC can connect with the same system, which itself, the system name is PAMNI or Nepal EHR, and telemedicine along with the capture of the data is possible with the same platform. This is the ecosystem. OpenMRS is the clinical module. Udo itself is the open source module being used for the hospital supply chain and other enterprise resource planning. DCM4C for the X-ray, OpenLS for the laboratory management, and all those data are being used for the national aggregated HMIS system and the insurance claim processing and claim management. So these are the countries where this system has already been scaled up. Around 400 sites around the world, 50+ countries are using the platform because this is designed for the low resource setting, and we don't need to go through the huge investment from the infrastructure side, and with a minimal investment with to the hardware. This platform is easily scaled up. Here I can see Balram, who is also using this platform to provide the telemedicine services in coordination with Dr. Uday Model Hospital, and the same platform is being used and is very stable with a minimal investment. Some of the scenarios that we have achieved so far in terms of the implementation, there are almost 26 districts along with the PHC, primary healthcare center level hospitals. Recently, we have completed one of the use case for ophthalmology services, where BAMNI itself is being used for the hub and spoke, where hub hospital is connected with the 4 different outreach centers to provide the consultation of ophthalmology, and is working smoothly with, as I mentioned, with the minimal investment, because affordability is so important in terms of the scalability of the digital health tools. And municipality model implementation in support from Telemedicine Society of Nepal and Kathmandu Model Hospital currently is being used with the 2 different sites. What is the end goal? The end goal is to be connected with the national system, where all of the point of services will be connected with the national registries. My previous speaker, he was mentioning about the Ayushman Digital Health Mission. So that's something we envision to implement in Nepal as well. And I think we are already into that journey with that plan, where national registries will be there, terminology services will be there, national ID has to be used, where Nepal is in the verge of implementing national ID to all of these civics, so that it will be easy for us to manage referral as well as the identify the patient without with avoiding the duplication of the care. So just to add on this, Nepal government has envisioned the interoperability lab, where Telemedicine Society, ICT4D, SUNY Computing, we all are actively engaged with ministry and trying to support government to follow the open health information exchange platform and onboard the private implementers as well as the private EMRs along with the national level digital health platforms. So here are the few publications, to name few. We have a few other implementation as well, where we have published as a part of evidence, so that this can be as the advocating points for Nepal government. And all of those data, what we collect, as I had mentioned earlier, the system OpenMRS or BAMNI itself is connected with DHIS2, and this is something, the dashboard that we can build, and we have already implemented with few of the sites as the part of the MNE, and administration and the policymaker and decision maker are already using this dashboard for the improvisation of the health. We all of the entities wherever we are engaged with are strongly supporter and practitioner for the digital public good, which means we try to incorporate the open source proven platform to scale in Nepal, who are already in the digital public goods, and which is suitable for the countries like LMSC, countries like Nepal, where digital literacy is low and can be scaled up with health posts to provincial or regional hospital. That's why we follow the digital public goods, and somehow we have been successfully implemented to different unit hospital and the district hospitals. So far, considering with the time, I think I'd like to end the presentation, but I'm very happy to further get the questionnaire from the audience. Thank you, Dr. Uday.
Thank you, Sanjay, for such a nice presentation. So is there any question or comment to Sanjay? So if there is no question, I would like to ask you a question. So what is the most faced challenges that you have faced for this implementation?
That two level, thank you, Dr. Uday, for the question. I think that's a very practical question that we face every day during the implementation. There are two challenges. One is the policy challenge, because I feel during the implementation time, we are chasing government to materialize or make the matured e-health strategy, digital health framework, where providers, implementers, and health IT professionals can work together. So that is the one challenge from the policy side. And other side is the acceptance, which itself is always a challenge. I think this is not the new story for global world. So clinical acceptance and the reluctancy to change the behavior for what they've been using their current platform. So these are the basic challenges, but I think there are so many challenges itself, because human behavior change itself is not the easy job and easy task. So primarily two different challenges.
Okay, thank you, Sanjay. So, Dr. Anil, are you ready there? Dr. Anil?
Stop sharing.
Sanjay, will you please stop the sharing? Dr. Anil, are you there? Sanjay, will you please stop sharing? Sanjay, this one. Okay, Dr. Anil, are you there? Slides is on. So I think Dr. Anil, are you there? We can see him there, but yeah, he's not responding. So we'll go to the next presentation. Is my slide visible?
Yes.
Yes, thank you. So I'm actually going to the theme topic, that is digitization in rural healthcare, dream or reality. I'm Dr. Uday Koirala. I'm Senior Consultant Surgeon and Head of Department in Surgery Department, Kathmandu Model Hospital. I'm also working as a Chairman in Telemedicine Society of Nepal. So looking back to our connection, networking, it was started back in 90s era, and there were some publications where these rural villages were connected through internet. Mahavir Poon, he is one of the Magsaysay Award winner who has been working hard for this digital health and telemedicine to improve the health outcome in rural healthcare. So in May 2002, there was a first long-range wireless connection to Nangi. And those were the days when we used these radios and VSAT in trees and roofs to connect city to the villages. Some of the towers in trees and roofs we used solar when there was no electricity, and when there was storm or heavy rain, all these were gone, and we had to re-establish. And from 2006, we started to have a regular connection with Gauri Sankar Hospital in Dolakha. It was a hub hospital for Kathmandu Model Hospital for different satellite centers there, and it was a satellite hospital for Kathmandu Model Hospital. We also tried with different digital tools like sending the ultrasound and ECG reports. By 2011, we had connected more than 13 remote areas like Trisuli, Jomson, which are different peripheral areas of Kathmandu and different rural areas. Actually, because Nepal is a mountainous and hilly with high Himalayas, so there are so many villages that are very difficult to approach by road. And if the network is better, then the healthcare there can be improved through these connections. So now Dr. Uman, Michael, and all, even Sanjay, they all have already presented and made my presentation easy, that there are signs that connection through this network, through this internet is possible, and improving the healthcare system in rural is now possible. Now we have this society, Telemedicine Society of Nepal, which is working to improve the digital health in Nepal, along with different partners who are working in digital health. And we had history of many eminent personnel in digital health who worked in this part. And now we have come with different guidelines that is for medical practitioners, as well as to start telemedicine program in the central level and as well as a different province level. Now we are understanding that telemedicine should go hand in hand with digital health, and it should be understood as a system, not as a unit or not as an organ. So we need digital devices, health informatics, and more importantly, this capacity building to improve these digital health initiatives. Our universal healthcare coverage, to improve that, especially for the country like ours, this digital health may prove to be the best, but there are so many hurdles, as you all have mentioned, and I think we should more focus on capacity building, not only in the user part, but also from the provider part, that acceptance and readiness of the user as well as provider is very much important, and that I think we should gain through this capacity building, different trainings, different programs, this experience sharing. And I think this APAN is also a very good platform to share our experiences, to share our knowledge, and to improve ourselves. When we are planning for the future, we have suggested for forming a national digital health steering committee, national technical working group in ministry level, with a different digital health resource center and telemedicine resource center at different level. We have 3 tiers of government: central, provincial, and local. And our health is also divided according to this. There is central system, central hospitals, provincial level hospitals, and local level hospital, health post, and primary healthcare centers. So this digital health resource center will be responsible for planning, budgeting, supporting this technical part as well as health and medical part. It will also help in standardization, monitoring, and regulating. So this system will work on all, like promotive, preventive, curative, rehabilitative, and palliative care, which also will include all health professionals like doctors, nurses, paramedics, public health, medical education, policymakers, administrators, and it will further update for the help to form the minimum standards and procedures. It will help in legislations to form the guidelines. And I think we should start with provider to provider services so that it will be more sustainable and will work as a model to expand to the clients. And it will also give the standards for technology, for interoperability, privacy, and security. So the approach, we also tried with bottom to top approach. We went to different villages, different rural areas to establish this digital health platform, telemedicine platform, and to connect to the center. But because of the readiness and acceptance, so I think we have to change that, and it should be started from the top, building the model in the top and to go to the bottom. And this EHR should be government-owned, central EHR, where all these telemedicine platform should be there, as Dr. Uman has very nicely mentioned about their platform. And we should have minimum standards in digital health and telemedicine, start with pilot projects in certain areas and hospitals according to budget, because to start with will be a huge budget, but slowly it will be implemented in the current health system, and the running cost will be low. We should work on this awareness, mainly in the user part to make it user-friendly, and also digitalization of the healthcare workers for their readiness and acceptance. We should work on this capacity building, forming this department, resource centers, training the service providers, mass awareness, and technical assistance sharing with municipalities and BDCs to make the local leaders, these policymakers, also aware as well as accept the digital health transformation. And also, as we all know, this incentive and reimbursement to the human resources is also one of the important part. So with this, I would like to complete my presentation. If you have any questions, queries, please, you can. Are there any questions or comments or any suggestions?
Okay, can I have a question?
Yes, yes.
Sorry, now have a go.
Yes, Dr. Moria. Yes, Dr. Moria, yes.
Okay. No, maybe now it's okay. Okay, to install the rural healthcare in many countries, it's very important how to involve the many stakeholders here. So of course, people who are enthusiastic on telemedicine is quite important, but also how to collect the colleagues to make it real. Of course, same in digital health. Do you have any idea how to install or how to collect these colleagues?
Yes, that is always a big question for everyone. That last question also, mine was also the same to Sanjay and to Dr. Uman. So it's been a challenge, and I think we need some dictator in this digital health to start with, some dictator who can dictate to make them compulsory, the presence compulsory, and to compulsory use of this platform, and compulsory giving feedback, compulsory regulating, monitoring. So in that way, but before that, we have to have this capacity building, training, giving information. I think that is more important.
Dr. Uday, can I do a comment on this one if I can?
Yes, Dr. Anil, please.
Yeah, so I'm thinking, like I'm from United States, so the way how I look at is we call it a patient experience. The people who use that, they should feel like, oh, this is very helpful. I should go back again doing this thing instead of driving hours and hours to see some doctors out there, right? So what our experience here is, for new generation people, we call Gen X, they are always on a phone, telephone. So they feel very comfortable using this kind of thing, platform. So they are constantly doing like a telemedicine and stuff like that. Versus, if we are looking at like a 60-year-old patient, 70-year-old patient, they are always like, I don't like that. I don't want to see on the screen. I want to have some sort of like a physical connection or something like that. So what it means is basically those people are not having like a good experience. They don't feel like they want to go back again. So during the COVID time, like Dr. Uday said, yes, during COVID time, everybody was forced to use this thing. That's why it is so popular. Now, COVID is gone. Now patient has more choices and they don't want to go back. Some people don't feel like this is, very working good. Sometimes the connection is not good. Sometimes, overall, I have to say it's a patient experience. If we can focus on a patient experience, they will come back and they will do it because that will save the money and, a lot of other things. That's my opinion. Thank you.
Thank you, Dr. Anil. So I think we should go to your presentation. Please introduce shortly yourself and start your presentation because we are lagging behind time.
All right, I'm sorry. Okay. So yeah, I'm Dr. Anil Suwal. I am from Winchester, Virginia, United States. So I am a medical director for one of the Valley health system in the United States. So I have several clinics, I look after. And so I led the team for telemedicine thing during the COVID time too. I have definitely, several experience on, like I say, more than 1,000 patients in telemedicine thing. So can I see my screen, Dr. Uday?
Yes, I think you can. Can you? Is it okay?
Okay, let me see if okay, sure. Can you see my screen?
Yes.
All right, so yeah, so I'm gonna just briefly talk about today, like a utilization of telemedicine, rural community. I'll focus more on a rural community, why it makes sense, like a utilization and things like that. So first of all, talking about rural or underserved community, we name here like underserved community. Basically, as every country has, there will be lack of healthcare providers. We'll have a limited infrastructure, limited access to healthcare, and some people out there have let's say like a poor adaptability because of the education and whatnot. And so just try to think about, what will make a rural community. Let's say like there are like 5,000 people in a community. That could be one of the rural community. Now, does it make sense to make like a 1,000-bed hospital over there? Does it make sense to bring every specialty, let's say cardiothoracic surgeon in that community? Probably not. There are 5,000 people. The population won't, will be suffice to have all those subspecialty people out there in that community. But however, those people go through some of the problem like that. They may need a cardiothoracic surgeon, or they may need a neurologist, they may need a pulmonologist, they may need an ophthalmologist. So, those people, even the 5,000 people, even though the service is not there, they're still gonna need that. So how do we get those things? Do they travel like 2 hours to get those service? It is hard. Yeah, they are doing that. So there's something like we call gap. There's a gap between like a need and versus, like a supply. So that gap can be filled by the telemedicine. And that's when it comes like a telemedicine, why it is so important in, like a rural communities. It will definitely increase the access to the healthcare. So, those rural community people now can tap into different like a medical community. They can get a doctors from different part of the country. Even if everything works well, they can even get access to healthcare from all over the country, from the global area. So there will be definitely more access to healthcare if we can make like a telemedicine very smooth. And obviously, you will be consulting specialty people, second opinion, third opinion from different people out there. So the quality of care for that community gonna go high if we start using that telemedicine thing. And obviously there'll be less healthcare expenditure because, like I said, to serve that 5,000 community, either the doctor has to go to the community or the community has to go to the doctor. There's a lot of travel costs, a lot of other things. So that can be saved by this, like a telemedicine thing. So this is a really good bridge to have to get a better, like a healthcare with a less expenditure. So that is why also I think that telemedicine will make more sense. And I know Dr. Uday is going to talk about dream versus reality. We dream, and I think, unless we dream, we can make this thing happen. So we are dreaming this thing. I think it is moving forward. I know it's going to probably take a time, but I'm pretty confident, down the road, this telemedicine grow every day. So now, what are the tools for the successful telemedicine thing? Like I said, first of all, we need to have a very reliable internet service where you don't have a call drop or you have to pause to listen to somebody. So having a very smooth, internet connection, that can have very good patient experience, and as well as for the doctor as well too. They can spend less time on trying to understand what the patient is saying. And obviously, we have a lot of digital equipment, like previous provider has already shown that too, like a stethoscope, camera, otoscope, portable ultrasonogram, different kind of thing, where the doctor or other part of the country or even the world, they can see what is really going on with the patient. And I would probably suggest, the patient need to understand all those things. Your ear being looked at, your lungs being listened, and things like that. So that would probably help you too. And obviously there should be some digital, user-friendly digital platform. There are a lot of software these days where doctor is connected with a patient, and that digital platform need to be very user-friendly. If something happened, they should be able to easily troubleshoot that so that it won't be waiting 30 minutes for Dr. Uday to see the patient because there was some a technical problem. So it should be very easy to troubleshoot and connect and things like that. And there should be adequate training for the staff. That will also help, how to go around if one platform is not working, how to get a second one running, and how to use all these like a digital stethoscope, ultrasonogram, and otoscope, things like that. And obviously, most important part is a community education. Again, we should not forget that we are making all these things for community. So if the community is the one who is not using, regardless how good telemedicine tools you have, it's not going to work because they are the consumer. So always it has to be focused on the community, where I call it an end user. Those are the people who will be using this service. And if they don't use this one, regardless how good it is, it's not going to work. So that's why, we always have to focus on what the community need. Do they know how this can be done? And are they willing to, get this kind of service? So I think your community education will be the key feature to have a successful telemedicine, in my opinion. So, with that, I'm gonna just go through some like a quick example here. Here's one like a school telemedicine project we've been doing in our community. We call it an underserved community. It's about a 2-hour drive from where I practice. And there's a school, like a kids, about 500 students over there. If the children is sick in a school, there's a nurse in a school who will triage the patient, and the nurse has a capability of doing flu test, COVID test, strep test, all those kind of things. And then they will, connect, call us and they say, hey, I got a patient to be seen here. And then we'll start like something, the device I'm showing over here. We have a device like that, and we'll see the patient, through this device, through like a platform called Teladoc. And we use that, to see the patient. I can zoom the camera. I have a stethoscope or otoscope, everything out there. And so we make a diagnosis. And then we, I send a prescription electronically, and the nurse will explain everything to their parents. And what it does is basically, typically on a regular scenario, when a kid is sick in his school, the mom and dad has to go to his school, and they will pick up the kid, and they will drive 2 hours to see a doctor. They have to wait there for 30 minutes if they are lucky, wait in a waiting room, and then see the doctor and get a prescription, and then go home another 2 hours. So their whole day is gone just by traveling and arranging all these things. So this will save a lot of time for everybody. They will save a lot of time for travel and the money wise too. So I would definitely say this is a less expenditure, and it is very popular now. So we are building more and more. So other school willing to participate on this kind of thing here. Now, second thing, I'll just briefly talk about this, and then I'll wrap up here. So telestroke program. So once again, in the United States too, every part of the community is not like what you see in New York. We have a community here, 2,000 people. They are 2 hours, 5 hours away from our a big hospital. Those hospitals, they don't have a capacity to have a neurologist in hand, in the place there. So if somebody, but unfortunately, among those 2,000 people, they may get a stroke too, right? So, if they have a stroke, they can go to the local hospital. They'll get a CT scan, and then let's say they have a stroke kind of thing, and they will be connected with a larger hospital network, big hospital, Washington, D.C., New York, and something like that, where they will have this kind of program. The neurologist will be on the screen, and then the local doctors and some other, we call a physician assistant, nurse practitioner, they will guide through on this, how to do the exam, what is the thing, and all the test results, and then all the CT scan, MRI, if it was done, that can be reviewed the other side, in Washington, D.C., New York, somewhere else there by the neurologist. And then they can determine, okay, this person need, let's say it's a, kind of a ischemic thing. Now we have to start, a thrombolytic within 90 minutes. Then the patient can actually get a treatment right away in their hometown. If they have to travel, even airlifted, it's going to take more than 90 minutes. You are already out of time zone. So you see how, it is can be really life-saving thing. So telemedicine, again, I know a lot of people think telemedicine just FaceTiming and things like that. It is not. And if we can use it in a better way, we can really integrate it very well with our day-to-day practice. So my request to everybody, think about end user and, trying to integrate all this technology and, just make a medicine a little bit better with the help of telemedicine. So that's my 2 cents here. If anybody has any question, I'll take a question here. Thank you.
Thank you. Thank you, Dr. Anil, for this excellent presentation. So we are already running out of time, but if Dr. Moriyama allows to have this off-hour discussion, so because it's there are so many good people here, so maybe we can have some discussion here.
Okay. All right. Thank you for a nice presentation, Dr. Anil. I totally agree with you. The community education is the most important part, I think, and also very difficult. In Japan, even during the pandemic, telemedicine doesn't expand it in community, actually. So the reason why is the patient says, doctor do not request us to do telemedicine. And doctor said, patient does not say something to install telemedicine. So that's a big conflict in our country. So if you have some resolution, some way to solve these issues, please let me know.
Yeah, I know it's challenging, doctor. You know, like it's same thing here in the United States too. Like how much we were seeing during the COVID time, it has gone down. Like I would say, in my urgent care, we see like 90% of the visit we do telemedicine during the COVID time. Like, you know, Dr. Uday say at that time, it's kind of like a dictatorship, right? Everybody forced to go through that. And that's why, and now it is gone down to like a 10%, 15%. And our, you know, experiences, those people who are using telemedicine mostly are like a young folks who are very comfortable with the software, online appointment, doing all those navigation kind of thing. So it is a little bit harder for like those older folks. But again, you know, like there's always like from provider side, we can train some people there. You know, like we can help this patient to have navigate all those things and have a better service. So I think, you know, like you said, I agree with you. There's just sometimes like doctors say, well, patient doesn't want to have that and things like that, you know. And so if we think about like, and the patient also said like, oh, well, there's no doctor, you know, to do that one. So it is feeling uncomfortable between both. And that's why training is necessary. That's why education is necessary. So if we can train all our provider, hey, this is how you get it done. See how quickly you can get it done. You know, you show the thing. I call it a lead by example. When I do something in my clinic, I first show them in the beginning, everybody asking me, how are you going to do telemedicine? How you see the throat? How you see the, you know, and I show like there's a different way of doing that. The exam doesn't necessarily always mean that you have to put a stethoscope. Just by looking at you, I can say you are looking sick or you don't look sick. You know, so that's a lot of like a visual stuff, you know, we can use in our like a telemedicine thing. We have some protocol, you know, what need to be done. And so, you know, I'll be happy to share all those kind of things, you know, but yeah, I agree. So training and education is a pillar, you know, that's how we can connect these two people. And then, you know, obviously the middle part, internet, you know, infrastructure, you know, all those platforms, all those things. Some administrative people help that. I think that will probably make a difference. Thank you.
Thank you. Thank you. I would like to ask Mike. Michael, you are here?
Yes, I'm here.
Yeah, so with your this smart healthcare, this knowledge and experience and technology, how can we have this sharing, mutual sharing, and how can we learn from you? So is there any platform that we can have mutual cooperation for this?
Yeah, I think that everybody talking about the education, yeah, which is vital, okay? Without a good understanding and the awareness of the service value, no people want to take it. Okay, so it is quite important, okay, to have a government as our partner. They can command the local clinics doctors and the nurses and the caregivers. You have to do something for those people, okay? And for the daycare center, for those elders, they, they don't have any digital capability, but they used to take a measurement every day, but they don't want to do it because after they take the measurement and if his blood pressure is very high, but nothing happened. But right now it's changed. When they found that their blood pressure become very high, above the red line, then a call from the clinic nurse, care about her and ask her or him, say, what happened to you? You need any assistance? I can arrange a doctor to do the telemedicine for you. Those elders become say, oh, that's great. I got service, not just measurement. Okay, so they learn. And then we invite their family to join it. Their family members are, oh, it does works. I'm very happy, in my office, in my factory, very far away from my village, but I can join the consultancy, with the doctor. So people have to conceive the value and the benefit, then they will adopt it. And we use how we educate enterprise to accept our service, because enterprise, they have the responsibility to their employees' healthcare. When they donate their money to make the government to do the healthcare for the rural area for those elders, they say, okay, it's a good way. Our employee, especially those senior management, they also have chronic disease. We can take better care for them. So that's an education process. We learn in Taiwan. Thank you.
Thank you. Thank you. My last question to Dr. Dennis. Dennis, are you there? Dr. Dennis?
Yes.
Yes.
Sorry.
Because I think you are the most experienced among us in this digital health platform. And I would like to ask you, how much satisfied are you with the development of this digital health in your area and Philippines as a whole?
Well, of course, we were very, in a sense, idealistic at the start, no? Because when you have the technology, you think that it will be easily adapted or to facilitate things. But what we have realized actually is that the governance, the dissemination, the community awareness, the skill of the people that needs to implement this takes time. It does not happen overnight. No? So we have actually shifted to more governance related and capacity building work, because the technology will always be there. The technology can be developed, can be commissioned based on what we need, but the sustainability and the sort of implementation process that you need over time does not happen overnight. No? So there's a lot of work that needs to be done. As you have shown in your presentation, no, when you started with the technologies that you started introducing and working on, and then later realizing that you have to connect it with a bigger system, and then even realizing that the community part is important, the community of practice is important, the capacity building is important, because without all of those things happening or being the technology will be there, but if no one is using it or no one is maintaining it, then it does not do what it's supposed to do in terms of the work that we're doing. In a sense, we have to be patient. We have to be patient in the work that we're doing if we want to make things happen. I hope that answers the question, Dr. Daya.
Thank you. And now last comment and also suggestion with closing remarks from Professor Chiang. Professor Chiang, are you there?
Yes, Yeah. Yes, we as an engineering, I have this great privilege to serve our medical profession to help people, and as the technology is improving, and we saw so many doctor or medical profession, they're willing to use this technology to serve other people. Indeed, I really feel very encouraged, and I hope in the future we still can provide more service, good service to you guys, so that more people will benefit from your supporting your medical care. So I really looking forward we can have a more discussion like this, and thank you for your nice arrangement.
Thank you. Thank you. So Dr. Moriyama from venue, is there any final?
Yeah. Okay. Please give me a moment to stop the echo. Okay. Okay. Thank you, Chairman Udaya, and also all presenters and discussants to make this rural healthcare session fruitful. Actually, as I mentioned, unfortunately, Japan has a very less experience in telemedicine still. So that I learned a lot from you guys, and also I should make a brainstorming to how to install the telemedicine in Japan. So I hope to learn a lot more and more from you guys. Thank you for.
Okay. Thank you. Thank you all.
Thank you. Thank you all.
Thank you. Thank you so much.
Thank you.
Thank you.
Bye-bye, Dr. Udaya.
Bye-bye. Bye-bye.